name is Joy. I'm with Pediatric Neurosurgery, the nurse clinician. We have 3 pediatric neurosurgeons here and 3 nurse practitioners and 2 PAs and myself. And we're going to talk today about all the drains, and it's in air quotes because a lot of people call them EVDs when they're not really all EVDs. You have the same kind of setup, but they're very different. So one of our goals is for you to understand the differences in the types of drains and then the devices that we use on our neurosurgery patients. So we're going to talk about the function of the different types of drains, the types that we have, how to set them up and maintain them, and then the nursing care for the EVDs, no matter which kind of EVD that you have. Here's my Anatomy 101 for you all. This is kind of what you need to know to understand a lot about the drains. So we have the cerebrum and the cerebellum, and then we have right here ventricles with the water spaces of the brain like we call, but they're really ventricles, and they are where CSF is made and circulated. So you have 2 right here, lateral ventricles. So you can only see one because these are side by side, okay? So you have 2 lateral ventricles, the right and the left, and they drain into the 3rd ventricle and then go down this little corridor to the 4th ventricle, here. And then it goes, reabsorbs in the venous system of the brain. It also circulates up and down the spine. So that point is very important when you talk about some of these drains, about the fact that it's connected in the brain and the spine, and that'll we'll go over some things that affects. So in pediatric tumors, they're mostly right in this location, so that will be part of what we talk about that backs up the CSF, and there's several other reasons why you might have increased CSF, and then we'll talk about some of the ways that we take care of that with the different devices. Okay, so the external ventricular drain, we're not talking about the air quote one now, we're talking about the real one. They all look like this, and we'll go over that up close afterwards, but EVDs are used sometimes with trauma. As you know, there can be lots of going on in trauma, but sometimes we just need to get something out of the brain, and if it's not blood that we can get out in a craniotomy, sometimes we need to just remove some of the CSF that's in the water spaces to make the pressure decrease inside the brain. So we may put in an EVD just to help get that CSF out, and sometimes there's even blood in those ventricles from whatever accident, and we need to get the blood out of there just so that we're not causing increase in the cranial pressure. We also do use EVDs a lot of times for tumor patients. Like we talked about, that one in the 4th ventricle or the posterior fossa is where the majority of pediatric tumors are located, and they can cause the obstruction. And a lot of times that is what the emergent issue is with these kids. They come in and they have all kinds of symptoms, and then we do a scan, like even a CT scan, and we find that they have huge hydrocephalus from this tumor that is in the way. So we still need to get workup and imaging about the tumor, but that hydrocephalus is what could kill them tonight. So we have to sometimes rush to the OR to put in an EVD to relieve that pressure, and then that allows us some time to do the other imaging we need, like MRIs of the spine, and different evaluations. And then with myelomeningocele, a huge percentage of patients that are born with myelomeningocele on their back, a defect on the back, the disease is called spina bifida, but when they're born, it's a myelo. So a lot of times we have to address hydrocephalus in them. There's probably about, I don't know the amount, I've always said 80, but it seems like it's a little less than it used to be. I need to do a little research on that. But a lot of them have hydrocephalus as well. So we're healing, we're trying to close that back defect that's on the back, and if they're under pressure in their head, it can keep that from wanting to heal or cause it to leak. So a lot of times we'll need to put in a drain to reduce that pressure again until we can get the back to heal. And then they may or may not need a shunt, but we can determine that with a drain. The catheter on an EVD is in the ventricle. That's what the V is for, it's ventricular. So the actual catheter, and well, you saw where the ventricles were on that. So the catheter would go straight down in those holes where the ventricles were. Usually it's kind of where the right and the left lateral ventricles meet. And then the catheter exits the body and is attached to the drain. And that is what an EVD is. Catheter's in the ventricle and it's attached to this drain. We're also going to talk about subdural drains. They're a lot different. Well, let me back up. The CSF that's coming out of the EVD should be crystal clear like water. It shouldn't really have any color to it if it's in its normal state. If we are having bleeding in that ventricle, it could be bloody. So if an EVD has blood in it or has blood tinge, you need to know why. Because the average CSF, the normal CSF is clear, but if there's blood in it, the question is, why is there blood in that? And it could be from having intraventricular hemorrhage, which is what we expect. But you need to be asking questions when things aren't their normal way. Okay, so subdural drains, as we talked about, let me show you on this picture of our little anatomy picture. So like I said, the EVD is going to put a catheter in here. Usually comes like this. And there's holes in the end of it so CSF can drain off to this bag. In a subdural drain, the blood is not in the ventricles, or the ventricles are not what we are trying to drain. It's the subdural spaces. So in these little kids, and the majority of our kids that have subdural drains are from shaken baby. And that is, you're shaking them, and these vessels that are out here can get severed and rupture and cause subdural bleeding here. So when you have the hydrocephalus like the EVD, these get bigger and push the brain out, causing compression. With this subdural drain, we put the catheter here because the blood is here, and as it is expanding, it's pushing down on the brain. So either way, you're having an increase in cranial pressure. But this one, the catheter's not down in, it is just right under the dura. The dura, if you remember, is the lining around the brain. So we go right in between that, under the dura, hence the word subdural. So you really need to know the difference in those two. And then the drainage you'll get on those is we expect it to be bloody because that's what we're draining out. So, and it's kind of older looking blood, kind of dirty, darker, and not the bright red blood. If it does change to bright red blood, we would need to know that because it could be something else that's going on. Oh yeah, I did talk about how sometimes that's from abusive head trauma. It can also be patients that have hydrocephalus that are over draining for some reason. That makes the brain kind of sag down. So same thing, you can rupture those vessels and cause subdural bleeding. And on the subdural drains, a lot of times we have them bilateral because those non-accidental trauma babies have the bilateral subdural hematoma. So we put one on each side. These are some pictures of the two. As you can see, on the one on the top over there, you can see the ventricle spaces and where the catheter goes, and why we are like zeroing. When I show you the 0 point on the drain, you can tell it's kind of like right where those ventricles are. And then the bottom one is showing how the subdural space collects subdural blood and pushes on the brain. So an externalized shunt, this is quite different. An externalized shunt is not a drain, but it is actually externalized to this drain that we'll look at. So to be an externalized shunt, that means the kid already has a shunt. They live with a shunt all the days of their life, their school and home, and they just require shunting of their CSF to have not an abnormal pressure in the brain. So they live with that. Let me show you. So this is the ventricle catheter that goes inside the brain. All this is underneath. So we have a little semicircular incision. This goes in. We put the reservoir and the valve, and then this tubing is the other letter. It depends on where it's going. So it's usually in the peritoneal cavity, which is where all your organs are, that's moist in there. So the CSF that's under pressure makes this valve open up, and the CSF goes down into the peritoneum where this is. So lots of times, not lots of times, but several times we've had kiddos that have either a bad infection in their abdomen, pancreatitis, something like that, or they have a big surgery that makes this visible, and we don't want that to be contaminated with whatever's going on in the belly. So what we do is, this is still in place and it's under the skin. We make an incision either, like right here. Sometimes it's the chest, more often it's right at the top of the stomach, and we reach in and pull this out. So we get it out of the peritoneal space so that whatever's going on down here, we hope does not already infect this so that they get a CNS infection. So when we pull it out, this goes to the drain, and it's called an externalized shunt. The difference is we still have the valve in place, so that valve is still telling how much CSF needs to come off depending on the pressure inside the head. So it's not just you setting it, it actually still has a valve in there that's working. So you need to know that part because that matters. And then so we send CSF when we pull this out. You hope it did not get infected yet and the CSF is negative. If it is negative, we're good. We leave it externalized to the drain while they take care of whatever's going on in the belly, infection-wise or surgery-wise, until we feel like it's safe to put it back in. And we may not be able to put it back in the peritoneum because whatever's going on may have decreased the peritoneal ability to reabsorb that CSF. So we may have to find another place. We'll talk about that in a minute. So when we pull it out and we test the CSF and it's already growing something, we can't leave this foreign body in there that's growing something. So we have to not just take that part out, we have to take all of it out. So it's coming out of the brain, all of this is taken out. So as you know, this kid needs CSF diversion for their life. So we can't just leave the drain out. They still have to have some way to get that CSF off their brain. So then we put back in the EVD, the real EVD, not the air quote ones. So this kiddo may have been, you may have taken care of them and they had an externalized shunt, and you need to know that that means the valve is in place, and that probably we're waiting on some cultures and whatever else is going on in the belly. So if it is growing something, it all has to come out. We have to put something back in. So what we would put in is the EVD. So we put that ventricular catheter back in the water spaces like we showed on the anatomy, and then it'll exit the head and go to the bag, and it actually will be an EVD. So, and then that means this kid eventually is going to have another shunt put back in because we've taken everything out and you can't keep an EVD. So whenever they've taken care of everything in the belly, maybe we can go back in the belly, but it's time to put it back in. So they may have given antibiotics to clear the CSF of infection. They may have done another surgery to clean things out. But so we hope we can go back in the abdomen into the peritoneal cavity, but we may not be able to. So a couple of the other places that we might have to use to drain the CSF is a ventricular atrial shunt. So that'll be a VA shunt. It's not a VP shunt. So the catheter, instead of all that long catheter that you have for a VP shunt that kind of grows with them as they grow, you are putting it, you still have the ventricular catheter in the valve, and it just goes into the tip of the atrium of the heart. So that can be a little tricky because you're in the heart. And also if they grow, they don't have growth on that because we have to just put it in the tip. So we may have to lengthen that as they grow, where we don't have to do that on the peritoneal ones. And also foreign bodies in the heart can cause little clots on that. So we have to deal with that. So it's another alternative, not the greatest. They have to have good vessels. So we will be evaluating their vessels with imaging and stuff to make sure it's good before we do a VA shunt. The other one is a ventricular pleural shunt. So same thing, we have the ventricular catheter and then the valve, and then we go into the pleural sac where the lungs are expanding. So we hope that the CSF that comes off the head is able to reabsorb in that pleural sac. It's not in the lungs, but it's in the sac. So if it drains a lot, they may have compromise in their respiratory status with those. So we have to keep an eye on them with chest x-rays and such. So those are two of the most common other alternatives for a VP shunt. We've also had a few, which is rare, go into the gallbladder. It's kind of a last-ditch effort when the peritoneum is not good and the vessels aren't good and the lungs are compromised. We can do that. We hope that eventually, like if they have to have something else done with their shunt, that we can go back into the peritoneum at some point, if it's healed. And sometimes we have general surgery assist us in those surgeries, the VA shunt we do. And also if we're going back into what used to be a bad abdomen, sometimes they will assist us in that surgery as well. So we hope it can go back in the abdomen. I think I covered all that. So that's the picture of an externalized shunt. I didn't have a picture of that up there. So the catheter is in the ventricles, just like on the EVD, and then it goes, we pull that out, and you can see on the chest of that little baby that the tubing is externalized and it goes to a drain. You just can't see the drain, but there's a bandage over that. So sometimes it's kind of chest, sometimes it's upper belly where the externalized shunt is. Okay, so we're going to look at the drain a little closer. As you can see, these are the brain cards that we put on the shunt system itself. And these are filled out in the operating room so that when the surgeon is in there, he can decide what he wants the orders to be. And they may be on here before they actually make it into Epic as orders. So it's really helpful to have this, and they shouldn't leave the OR without it. So for the EVD, it's going to be circled EVD at the top of this. And then there is a place to write what we want the pressure to be, and that's what the surgeon will decide. And then there's also a line for 0 at the tragus. So it'll say 0 to something. So you're going to have that on here, and I'm going to show you that one. So we have an EVD. The first thing we're going to do, and all these instructions are on the back. It's step by step and it's color coded. So if you get this kiddo and you aren't familiar with it, read through that first so that you'll kind of understand what you're getting ready to do. The orders were more on the front, troubleshooting on the front, and the instructions are on the back. Also, our phone number is on the back. So that's the best way to reach us if you have a question. So we're going to start with what the first instructions are. If you are in the OR, you will be handed this out of the package. You know, the surgeon and babies over there, you're going to be handed this. You're going to put this on the pole. Always put the white cord over first in case you drop it. You don't want to drop this. Okay, so it's not where it's going to be, but at least it's, and it's clamped so that it doesn't matter. And then we're going to put it on the pole, these two little hooks, put it on the pole, and then you just secure the green screw to make it tighten. We're not worried about where it's at right now. We just want to get it secure on the pole. And you don't want to over tighten that because these little plastic pieces will break and then we have to get a new drain. And nobody's happy about that. All right, so the first thing we're going to do before we even acknowledge our patient over here, we need to make sure this drain is level. And if you can see right here on this, the bubble is in the middle. It's like a carpenter level. There's 2 lines and the bubble needs to be in the middle of those 2 lines. And it's not right now. So I am going to loosen this black screw, and this rocks back and forth to get the bubble in the middle. So I'm going to put it directly in the middle of the 2 lines that are on there and then secure the black screw. Okay? So you have to do that first, and a lot of people forget about that. So make sure you level your drain first. And then the next thing we're going to do is 0 to our patient. If you can remember where the order said we were going to 0 it to, is the tragus. I've put a little cheat dot there for you. It's this part of the ear, and I put a little dot there. So you push this button on the very front of it to turn it on. You used to twist it, but try to not twist it. Just push that button on. It goes off automatically, so you don't have to turn it off. But if it goes off on you and you're not done, you just turn it back on, okay? So it's on right now. We can't always move things around, but we can slide this around to kind of get in the right plane. And as you see, it's not on the tragus. It's too low. So you're going to use the same green screw that you put it on the pole with to loosen that, to raise it up. Light went off. There, you can see where the laser is now. So I'm going to raise it up on the pole until I have the laser light on the tragus, because this end is at 0 and now it's at the tragus 0. So that's what it means by zeroing to the tragus. It could be a different order where they're zeroing to, so you just would point the light to whatever your order is. On EVDs and subdural drains, it's almost always the tragus. So it's right there. I'm going to secure this there with the green screw. Okay, and now we've zeroed to the tragus. So we've got it covered as far as leveling and zeroing to the tragus now. Now we're going to worry about the pressure that they want. And I don't want you calling this what level is it at. It's not at a level, it's at a pressure. This number means a pressure. It's 7 centimeters of water. So it says it right here, centimeters of water. And also on the back, when it's giving you the description, it says centimeters of water. So pay attention to that, because there's two values on here. This is millimeters of mercury, and we don't use that here at Children's. And this is the centimeters of water. So you're going to be using this gauge over here. You're going to loosen this white screw, and you are going to, using the green numbers, put that red little mark over the top at eye level at the 7 centimeters of water. Okay, so that's the pressure number. Now that I had this all set up, I do need to take the slack up in this cord, because you don't want it to, like if somebody tightened it too much and it fell, you want it to be relatively hanging where it should be. So that's with the cord taken up now. So we've done all the things to this that we need to do, but we do need to do our line from the patient to the drain. So I would start with the patient. This, a lot of times coming out of the OR, you may never see it if you're not like in PACU, because this will come sometimes clamped off to the patient because the surgeon is in his sterile field here, and he clamps it off because that's what he can reach sterilely. So that will only be for neurosurgery. Nobody else will do things with this other than us, but we might need to draw CSF, to get a culture. We might need to flush it if there's some sediment in there that's stopping it from working. Occasionally we put medicine in there, but all of that will be done by neurosurgery, so you won't be messing with this. Your job is to make sure this is open, but you don't want to open it until you clamp your stopcock. So this one's off, it's going down, it's to the patient. So I can go ahead and open this up now because it's still gonna be clamped off, okay? So that one we need open. We have 3 slide clamps that come on this out of the package. We, for several years, have been cutting these off because these are 3 places where you might accidentally leave it clamped. And that's the #1 mistake with drains, is somebody leaving it clamped. So we get rid of these 3, but I want them on here for now to show you because you may never see them. And I want you to know that if they are on here, just let neurosurgery know. It's not an emergency in the middle of the night that we come cut them off, but just let us know that they're there so that we can cut them off. They're kind of hard and kind of slippery if you're cutting them. This is hard to cut, but this is not hard to cut. So you don't want to be doing that yourself because then we need a whole new drain and we've exposed the kiddo. So you have that stopcock and those 3 slide clamps that are gone, and if they're not gone, they need to be open. You just make sure that they're open. Then we have 2 more stopcocks on the drain, one here and one here. So this one down here needs to be clamped up off to the drain so that it will collect its CSF. It's kind of like a Foley bag where you have the graduated numbers and then you have the back over drainage bag where you dump it into after you measure it. This one's actually completely closed off. You can't dump it into that, but it's the same kind of idea. So you have to have this stopped up so that your CSF will collect in there, and we're going to check our output hourly, and I'll show you how to do that. And then you have this stopcock, which may be hard to see because the laser level's in the way, but it is off to the patient. So until we have checked everything to make sure it's correct, we're going to leave it off, and then now we are opening it up. And this kiddo was meant to have it open, so you don't want to take a whole lot of time before you get that opened back up. And like I said, we will check output every hour. It says that on the front of here. So what you will do to check your output on the drains, you come to it and notice how much is in the, how much is collected in the drip chamber. And then you're going to clamp it off to your patient because we don't want to do anything with it open. Clamp it off to your patient. And then we're going to open this up and let it drain down in the bag. And then we're going to stop up the sink again so it'll collect for the next hour. And then we're going to open it up to the patient. Okay, so a little troubleshooting. So you need to know that this is patent. It doesn't have to be dripping all the time because the patient's CSF may not be elevated and need to drain off. But if it's not draining, you know, the kiddo may have just had some pain medicine or they're sleeping and now their pressure is down, so it's not needing to drain off. But it's your responsibility to make sure that if this kid wakes up screaming or is increasing cranial pressure, that it has somewhere to go, that it can get through, and it's patent. So one way you can make sure it's patent, if you don't already see it dripping, is you can loosen this white screw and you can just slowly drop it down a little bit. Keep your hand on it. Don't get distracted, and you can go down slowly until you get drip, drip, and then you put it right back up to 7, where it was, and you're good. It's okay that you didn't have output for that hour, as long as it's patent. So if you drop it down like that and still don't get any CSF, you know, a couple drops out of there, then you need to put it back where it was, but then you also need to notify us because we may need to come do something for it. But if you've done all that troubleshooting already, you know, make sure your drains are open. Like I said, that's the #1 mistake with these. Make sure all your stopcocks are in the way that they're supposed to be and all your orders are correct. And then do that troubleshooting, and if it doesn't drip, then you just need to call us. And like I said, our number's on the back of the brain. So that is the EVD. So it should be crystal clear like water, as we said, and you'll have the same look to a setup if it's a subdural drain. So it's still going to come out of the head. We almost always still zero to the tragus for that. We might even have the pressure number a little lower because we're not trying to be as careful. We're careful, but we want to let more of the subdural out because that's what our goal is, to get that bloody drainage out of there so it's not pushing on the brain. So you may have a little bit lower pressure number. Remember, that's a pressure. And that's some of the difference on that. So with the externalized shunt, no matter if we had this wide open, the valve inside the kiddo's head would still determine at what pressure CSF drains off. So this is really just a collection chamber for that. We do make our number of the pressure that it is coinciding with that so that we're not like having a real high pressure here and then CSF is trying to drain off and it can't because the pressure on the drain is high. So a lot of times it may be the same or lower as that on that as well. Next, we're going to talk about lumbar drains. They're very rare. I kind of looked back over the last 7 years, over the cases we've done, and there was only like 7 lumbar drains in that 7-year period. It just so happened that like 3 of them were at the end of 2021. So you can have feast or famine. So we really need to talk about that. We've taken it off of the brain card and made its own card. It looks like this. So we don't have to circle anything because this is just for lumbar drains, so we're making it really different. It has the order for where the 0 is to be, just like the other drains. So on this one it says 0 to the externalization site, and the externalization site on a lumbar drain is going to be back at the lumbar area, kind of where the back meets the bed. So like that's too high, and I'm going to lower it. Move your hand, baby. It's right there, kind of where the back and the bed meet. So it has been written before 0 to the umbilicus. So if it is, you just point the laser light at the belly button. But in general, it'll say externalization site. And there's also a line for the pressure. It's not a level, remember, what pressure is this going to be set at? So there's a number. This one says 5 centimeters of water. Same thing, we are not going to use the millimeters of mercury. We're going to use centimeters of water. So this would be dropped down to 5 and secured there. We're also going to make sure that the level, before we even get started, we're going to make sure the bubble's in the middle, just like we did on the other ones. And then we're going to 0 it and put the pressure amount. And then what is different about these than all the other ones on the brain card? This is a lumbar drain. So the CSF isn't coming out of the head, it's coming out of the back. And remember I talked about how the CSF in the head is connected to the CSF in the back. So they need to kind of be flat, and we need to very carefully let a certain amount out. We're not going to just leave it open. We'll make sure this is open, and we're going to make sure this is clamped. And this is closed to collect your CSF, just like the others. But we are not going to leave it open for drainage. So all the other ones, we leave it open until we're checking our output. And on this one, we are leaving it clamped to the patient until we're doing our output. And the output on these are done differently. So there's a line on here too, it'll be filled in. This says drain 10 cc's every hour into the drip chamber. So it's going to be empty, and we're going to come to it this hour to check our output. And it's clamped, so I'm going to be watching the 10 right here because that's as far as we're going to go. So I'm going to open this up for drainage, and as soon as it gets to the 10, I'm going to close it off again so it doesn't drip anymore. We don't want 11, 10's what we're doing. Okay, so because that's clamped again and you've gotten your 10, we can dump that in the bag and stop it back up for the next hour. Okay, so I'm coming the next hour to do this, and I'm watching. I unclamp it to the patient. So that it's open to flow, and then you get your 10 cc's, but it's taken you 30 minutes to get your 10 cc's, which is awful, I know. So you would still clamp it off really fast. You have your 10 cc's, you dump it out in the bag, and you get it ready for the next time. So we've had it open for 30 minutes, but it's time to open it back up in 30 minutes. We're going to open it from when we opened it, not from when we closed it. So no matter how long it takes, you're still going to open it up like at the top of the hour. So we opened it at 7, it took 30 minutes, we're going to open it back up at 8, okay? So, and you wrote your 10 cc's down. Another scenario is we come to open this up, and it drains very, very, very slowly to get 10 cc's. So I can't walk away from this because it could just all of a sudden lose a bunch, which means CSF is going to come out the back, which means the CSF that's in the brain can also make the brain slouch down into the cranial cervical junction, which could it should crimp off vessels and cause a stroke. It could herniate your patient and they could die. So it's really serious how you handle these. So I'm watching it very closely, and I've only got 8 cc's and the hour is up. So I'm going to clamp it off because the hour's up, document my 8 cc's for my output for that hour, dump the 8 cc's down in the bag and stop it back up. And then, unfortunately, we have to open it right back up because it's at the top of the hour again. So this is a pain, I know. The ICU is going to make these kids a one-on-one when they get a new lumbar drain. They're going to be a one-on-one for at least 4 hours until we figure out what we need. And hopefully in that 4 hours, hopefully it's not taking that long, but if it is, we need to, as soon as we figure that out, we need to be calling the management and the PICU and let them know that this kiddo's coming. He's taking a long time to drain, and he needs to be a one-on-one. So as soon as we can communicate that fact, the better we'll have it getting nursing staff up for it. So yeah, and you can't walk out, even if in emergencies, you can't walk out with this open. If an emergency, like a code or something, you could clamp it off to the patient, but you need to have somebody come back in here and watch it and open it back up. You can't leave it with it opened. Okay, so that's the difference in the lumbar drain. It's very rare that we have them, and when we have them, you know, it may be 5 years from now before you have one. So you may forget about this. Just know that the instructions are on the back. Our phone number's on the back. It's totally different from the other kind of drains. And we would rather you call us and us talk you through things than for you to try to figure it out. Another thing with this, you will never drop this down to troubleshoot because we do that for the others to make sure it's patent. But this one, if you drop it down, you could have too much CSF come out. So we really only want whatever we write on the front, the order, only that amount to come out, and this would be 10 cc's. So you're not gonna troubleshoot with this. And it says it on the back. Just call neurosurgery if you have any questions. Don't try to troubleshoot. I mean, you will make sure that your clamps are the correct way. Like this one needs to be open, and this one's clamped, and this one's clamped. But that's the end of the troubleshooting. If it's not working properly or you don't know what to do, just give us a call. Neurosurgery. All right. So lumbar drains, I said they're very rare. Some of the things that reasons why we put lumbar drains in are reactions to other things. So this kiddo may have had a big spinal surgery and the dura was cut, so we have a durotomy, and they're trying to close it up and it won't. It keeps, you know, they have a spinal leak. So sometimes we can put these in, which lowers that pressure. You know, that CSF is pulsatile and it won't let the dura heal. So if we can lower the pressure a little bit with a lumbar drain by letting a little bit of that CSF pressure off, that should help that close off so they don't have a CSF leak. Another same kind of thing, but two different ways. If you have a fracture in the basilar skull, whether that be from a bad accident or something that's caused a fracture, or whether we intentionally made an incision in the basilar skull to get a brain tumor out, that, you know, when we go up through the nose, we have to cut through there to get the tumor sometimes. So either way, we have this bone that is not fused together currently. So with each pulse, you know, each heartbeat, your CSF is pulsating, and we want to lower that pressure so that it's not beating up against that so much, so that we can actually have the bone heal. It's kind of a last-ditch effort for a CSF leak. You know, we have CSF precautions, like, you know, they shouldn't blow their nose, they shouldn't use a straw, they shouldn't strain to have a bowel movement. But last-ditch effort is they might need to have a lumbar drain put in for those reasons. So it's kind of rare that we even have them because it's more of a reaction to maybe what else is going on. And this is where a picture of the lumbar drain, it shows how it's coming out of the back. And then that's just putting it in, as while the patient's on the side, they're usually going to be on their back so that you have a 0 point. And there is the drain card for them. And that's just a bigger picture of the instructions that are on the back of both cards. And this one addresses where it says to troubleshoot, it says except for the lumbar drain. So that's the main difference in that one. And this is just a picture of what I was showing you. You definitely want to hang the white white rope over the top of the pole before you do anything, just in case you were to drop it. The green screw loosens where the two green arrows are, so you can either put it on the pole or change it on the pole or move it up or down the pole when you're trying to zero the patient. And then you have the black screw, which you will actually do first, because you just need to get that bubble in the middle of the two lines just so that the drain is actually level on the pole before you zero to your patient. Not zeroing your patient. And at that point, after you get it where you want it, the 0 to the tragus or wherever the order is, you will take the slack up in the rope. And sometimes when you're moving it up or down, you have to give yourself some slack for you to move it, but then always remember to take back up the slack so that it's good and secure on the pole. And then, like I said, the pressure, which is the pressure inside the brain, is the number that we are setting that to, which will allow the CSF to exit the brain when it gets to that pressure and go to the bag for us to collect it. That's just talking about the stopcocks. If you have it off to the cap, the little word off is on that little arm. So whatever it is pointing at is what it's off to. So right now it's off to the cap, which means it's open to flow. And then the one in the drip chamber is closed so that it'll collect the drainage. That's just telling you that we will be cutting those off, and if you do see them on there, just let us know so that we can make sure we get those off of there so there isn't mistakes by leaving them clamped. We'll measure the output every hour and put that in Epic. When you transport with the patient with a drain, you're going to clamp it off to the patient, and that's going to be at the spot that I've told you is your stopcock. So this is open to flow if they're draining, and before your transport, you're going to turn it off to the patient. And then you take the pole with you. You always transport the drain on a pole. If a kiddo goes down to CT, they're attached to this, they're having trouble, we need to take them to CT scan. We can't do anything about the drain, so we will put them on the CT table, off of the whatever bed they're on, onto the CT table. You want to make sure that this is not getting caught, and you want to make sure the pole is close to the bore of the CT, because if they're going in, like the donuts here, if they're going in, you want to make sure that this doesn't get caught on anything. So it's kind of good to bring it down from the patient so that you can actually see it not pulling out of the head, because that would be bad. And then you can unclamp it while they're in there, because you're going to re-zero, like put them on this table, you'll re-zero to the tragus so that you can open this up while they're getting their scan, because if they're having trouble, we don't want to leave them clamped all that time. So you'll leave it open after you've already checked where they're at, and then when you come back out and you're going to move them, you clamp it off to the patient again, and then you'll go back to the room and re-zero them and set everything back up in their patient room. So troubleshooting these for the lumbar drain, like I said, you will just call us, neurosurgery, the number that's on the back of the brain or on the lumbar drain card. The first thing you want to do is always check the stopcocks. I said that's the number one reason that you might make a mistake, so always check those and make sure they're in the proper position for what you're supposed to be doing, and then check them again, or you can have even somebody else come eyeball it with you to make sure you have everything set the way that it's supposed to. Also, you want to think about changes that have been made to it, because if this kiddo is going to surgery tomorrow, we may want to make the ventricles a little bit bigger so that we can put a shunt in it. So we may raise the pressure so that instead of it draining off at a lower pressure, it's going to go up a little bit to drain off less, and that allows us to have the ventricles big enough for a target. But also, when you're making more CSF stay in the brain, you have to watch your patient more because they're more likely to have symptoms. So there's a balance there that we need. So if they're having too many symptoms, you need to call us because we may need to lower it back down to where it was. There is a job aid that's in the PICU's job aids where they are. For changing the bag, we want to change the bag of the drain, no matter which kind it is, when it's about 2/3 full. You need to start preparing to do that. This is a lot of pictures and a lot of words, but the main thing is you just need 2 people. So I would be your helper back here, and you're going to take this off. I put on sterile gloves and a mask, and you're going to move these back out of my way and hand it to me because I'm sterile and you're not yet. So I'm going to hold it out here, and then you're going to open 3 alcohol swabs the sterile way so I can hold them for you. And then you are going to open up your sterile field and dump your new bag on it. It's got your sterile gloves on it. And you want to open this bag up. There's a piece of paper around it. You want to get it out of your way because you don't want to be messing with that. And then you will you put on your sterile gloves, and you're going to come take the alcohol swabs from me one at a time, and you're going to clean the connection area and just drop it. And I say drop it so you don't accidentally hit something trying to throw it away. Just scrub it and then let it fall to the ground. Do that with all 3 alcohol swabs, and this will be your hand. So after you've cleaned this, you are going to hold on to this side. So we are going to screw against each other. And I've got the dirty bag in my hand, and you still have your hand on this because you just opened it with me. And you're going to pick up the new bag right here. You want to have this part in place, and you don't want to screw this on. You want to push it on. And then you screw with the other hand that has the little cap on it. Otherwise, your bag will turn out like this. So if you just push it on and then screw with the other side, it will come out the way you want it, and you put it back on, and you're good until you're 2/3 full again. This slide shows where how you need to hand off. So whether you are going to lunch, going to CAT scan with another patient, or your end of shift, you need to give a lot of information about these. I don't want you just saying this kid has a drain or an EVD. and he's been doing fine. You know, it needs some attention to that. So we're going to talk about, you use the letter of the word touch, T-O-U-C-H. You're going to tell them the type of the drain, because that makes a difference, you know, whether it's an EVD, subdural drain, or such. And the orders that have been written on the drain, you review those. We're 0 to tragus with a pressure of 7. And you want to tell them about how much you've been having out, because you may be gone a long time and you may have been only getting 10 cc's out every hour, and they're there and the whole thing is full, like they have 90 or 100, and they won't know that that's a little change from before if you haven't told them about how much you're getting out. So the usual output would be helpful. And then changes recently made, like I was talking about, if they're going to go to surgery and we've raised it, all your outputs are saying, you know, a lot more, and then they have them and it's raised, but you didn't tell them it was just raised, and they don't have any out. So things like that just help them to know what to expect and what they know that they should be concerned about. And then how your patient's doing, their exam. You want to let them know a little more detail than they're okay. You know, they're awake, or they're not eating yet, but they do, you know, they don't respond to us, but she's looking at mom, you know, things like that that just help them know right off the bat where this kid is in their neuro exam. Okay, this is talking about, you know, we have the drain, like an EVD, drain CSF off of the brain. Well, we might want to know what ICPs are. So we can do, transduce off of this drain with a transducer. Let me grab my transducer information. Okay, so I believe these packages are in Susan Webb's office. They used to come out of the Pyxis. But anyway, it's the drain. It looks like what you would do for a central line setup, but it's not, and you're not going to use the pressure bag. So what we really need out of here is, it comes with extra stuff on it, but all we need is this piece and this piece, okay? And then there's also a cap in here. There's a bag of yellow, different kinds of caps, and the one that we need is the one that does not have a hole in it. There's a white one on here. This one doesn't have a hole on it either, but it might be contaminated, so you would get one out of here that you can't see through it. It doesn't have a hole. So we're going to put that on the end here. So we are going to connect this. We have primed that, and we're going to connect this to the drain. This is usually done up in the OR, but it could be done later. It doesn't have to be done in the OR. So we're going to connect this, and then this will connect to your overhead monitor where there's a pressure box and a pressure cable, and that pressure cable hooks into here, okay? This slide shows where we're connecting to the pressure cable, so it'll look like that. And this is how I learned this. I'm a visual learner, so just to let you know, we have 3 points of interest. We have an overhead monitor, we have the drain, and the patient. I might call it an EVD because that's what this one is. So this picture, like that's on there, it has 3 points of interest. Only 2 can be working together at a time, and then you just turn it off to the other one, okay? So if we hook up this transducer, plug it in, our monitor is going to say to 0 it. So we need to 0 this drain to the overhead monitor. So for the moment, we're not connecting to the patient. We're just zeroing this to the overhead monitor, okay? So we would turn it off to the patient. And if you remember, the stopcock goes down when we're turning it off to the patient, because this is where they're at, the other end of that tubing. So we turn it off to the patient so that we can zero this drain to the overhead monitor. So when we want to check an ICP, you're going to have ICPs up on the overhead monitor that's continual, but they're not correct because we're open for drainage most of the time, because that's what we need to be doing. So we want to check an ICP of the patient. So we're connecting the patient to the overhead monitor to get their reading. So the thing we're leaving out is the drain. So we need to turn this stopcock off to the drain, which is up, because it goes to this. So we're going to turn it off to the drain. Give it a second to have a waveform for your ICP, and then you're going to note the ICP that is for this hour, and then you will change it back. So what we need to do with this patient most of the time is draining. So we are going to drain the patient to the drain. So we need to turn it off to the monitor, to the transducer. So, and that is this direction. So we're off to transducing. We're not checking ICPs right now. We're just draining the CSF from the patient to the bag. So that helped me understand. It's kind of confusing, and that's why we always, when we're talking about turning it off to the patient, you definitely need to turn down because it really matters in this instance which way you have the stopcock. Okay, as we talked about, you can have just an EVD that drains CSF off, or you can have an EVD that drains CSF off and transduce pressures. The other way that we might be checking pressures is without an EVD by using an ICP monitor. We are supposedly soon going to be getting different ones, so we'll have to train everybody on those. But this is the one that we are currently using right now. We've had some kids with these on there. I'm going to play a little video where Susan was showing you how to set up the ICP monitor. It's called the ICP Express, and we put these in on patients. A lot of times it's just really bad traumas who we need to know what their pressure is so we can treat them medically. So let's try that.
This is our new Codman catheter that we are going to be receiving. So there's two types of catheters that we will see. We will have one that will be our bolt, but we also have the capability now to have a tunnel catheter with our EVDs. So what you will need to know about these is that they are MRI compatible, meaning that we can take these down to MRI, but we will not be able to monitor while we're in MRI. So we will actually disconnect these when we're in MRI, and we will not be able to monitor our ICP, but we will be able to take our catheter in and get a imaging of our patient while we're down there. So what you'll need to know about these catheters is that when they come down from the OR, they will have a reference number that is a one-time number that they will get when they're up in the OR. This will be written on top of the Codman. It will be written in the OR notes, and it will be reported to you as well. We need to make sure that we know this number. This number, if you become disconnected, so if you go to MRI or you're untangling your wires and you disconnect your ICP catheter, you will need to know your reference number. So you have to know what this number is. Again, it's going to be on the top of your Codman, but if you, for some reason, that gets wiped off or you lose that piece of paper, it will be in your OR notes as well, and it should be reported to you in handoff. When your patient comes down, all this should be connected, but then you're going to need to zero to your patient monitor. So the Codman's pretty easy to use. It's going to kind of walk you through what you need to do. So we are going to kind of look at this monitor. It's telling us to go ahead and proceed to zero to the patient monitor. So when what you're going to do is you're going to zero to the patient monitor. You can press zero to patient monitor, or you can actually go over and zero on your monitor. So when you're, go ahead and press zero. Make sure our monitor says zero. My monitor is not wanting to say zero, so I'm going to actually go zero on my monitor. All right. And when it states zero, which it does, I'm going to go menu enter. And then it's asking me to press 20 or 100 for my patient monitor calibration signal. So you can do 20 or 100. I'm just going to tell you to always choose 20 because it's going to be quicker for you. So we are going to go ahead and press 20. And we are going to wait for our monitor to get to 20. This is the key piece. So we're going to sit there and we're going to watch. We're going to wait for our ICP number to go up to 20. And if you look at our Codman, it's going to tell you to do that. So if you ever forget, if you just look at your Codman, it's going to give you your instructions. It tells you to wait till 20, and then you're going to press menu enter once that's done. This is probably going to seem forever, but it should just take a couple seconds. We're at 19, and this is the moment where it just takes a couple more seconds. And now we can press menu enter, and we are calibrated. And here is where it's telling us transducer detected that the zero reference is 485. This is where you're going to reference up here at the top and see what was written down. Or if for some reason it's not there, look in your OR notes. This is that number that is specific to this transducer. So if this number is off by 1 or 2 or whatever it may be, you can adjust it. So you can go down here to adjust reference, and you can adjust it up by 1 or 2 to whatever you need it to be at. But you need to make sure that this number matches. So it says ours is 485. We are going to look. We're going to say that mine says it's supposed to be 485, so I'm going to accept that and press menu enter. All right, and now we are seeing our ICP, and it's matching.
I really need to have the actual monitor with me and talk to the patients, I'm sorry, everybody's patients, talk to you all, the new nurses, the ones that are going to be in the OR or in the PICU, because that'll be the only places that we will have the ICP monitors. So since I'm not here in person to do that with you, and I also, I'm not here for you to be able to play with this drain and touch it and learn how to do it yourself so that you're a little more comfortable with it, I would like for all of you all to write, if you're working in the PICU or working in the OR, I want you to fill out on this paper we're going to pass around. I want you to put your name, just where I can read it, and then your email, your Norton email, and also your cell phone, if you don't mind giving me your cell phone. And then when I get to look at all those, I'll come up with a time where I can maybe meet you even on the unit and bring it with me and kind of go over things with you and let you touch it so that you have a little better education about it than just watching it on the screen, okay? So we'll pass that around. Just please give me your name, email, and your cell phone. Okay, so these kiddos, when they go to MRI, that's one of the benefits of this ICP monitor is that it's MRI compatible. The actual monitor is not MRI compatible, but the tubing that comes off of them, which will make more sense when I show it to you, it is. So we can wrap it up. The little piece of it is about this long, and you wrap the cord around it, which is just about the right amount of circles that you need, and we're going to tape it to a gauze on top of the head. And it's in those round versions so that they don't feel any heat from the MRI, so it doesn't do anything to them, and then we have to leave the monitor outside of it. So then when we go back from MRI to hook it up to the ICP monitor, I'll show you how to do that in person. Okay, now we're going to talk a little bit about the nursing considerations for our neurosurgery patients, and it's kind of doesn't matter what device they have or what kind of patient they are. A lot of these are the same for our patients because it has to do with their intracranial pressure. You want to monitor their neurological status closely, monitor incisions for CSF leak, monitor incisions for signs and symptoms of infection, so if there's redness, swelling, drainage coming from it. We don't access this EVD for any reason. If it needs to be accessed, it'll be done by neurosurgery. It won't be by staff. Before we've had like infectious disease say, I need CSF, and your answer to them would be you need to call neurosurgery for that. So you don't need to get in the middle of that. They just need to call us if they want something from the drain. The laser level that's on there, we do have extras of those, and they're in the Pyxis, in the, no, they're not. They're in a, the extra laser levels are in a cabinet in the A&M hallway above the, I don't know if it's an airway cart, there's some cart, and right above it there is a little box that has the extra ones in case you lose it or if it's not working. I just clean them and put extra ones on the unit so they have replacements because they're kind of expensive. I don't want to charge the patient again. There's a carpenter level if the laser is not available, and that's what I'll show you that in just a second so I can show you how it's done. Like I said, you do not use the pressure bag for the transducer. That is just for the A-line, so it's set up a little differently. It just still uses that little piece of tubing. We don't like you to put IVs or scalp PICC lines in these kiddos because we kind of want to be able to use their scalp for us if they need a drain, or we don't want any infection, and we've actually seen where a PICC can like go in the brain or get infected. So we would rather you choose somewhere else to put your IV access in unless it's emergent. Obviously, if you're coding this patient or it's real emergent, then you might have to do that. We don't want any of our incisions to get wet, whether it's on the head or the back. We don't want wet rags, shampoo caps. When we bathe them, you just need to avoid the area that you don't have drips of water get on our incision, because if drips of water can get in, then also germs can go in with it, and we try really hard to keep their incisions from getting infected. You want to keep all hats and headbands, scarves, O2 straps, monitor wires, everything off of the dressing. So it needs to come out another direction. Just don't cross over our incision or our dressings. Okay, when to call neurosurgery. If you do see the clear fluid leaking, that is CSF, and that can be emergent. So you need to let us know if you see CSF. If there's any other kind of change in drainage that you've noticed, significant change in the amount or color or whatever, we need to know that as well. If they have worsening or persistent headaches, a decreased level of consciousness, increased sleepiness or irritability, bradycardia or desaturations, vomiting or decreased PO intake, less interest in a bottle if it's a baby. Pupil or eye movement changes or sunset eyes. You can have, with pupil changes, you can have them unequal. You could have one eye turned in and kind of pinned in. You might have some nystagmus movement that's not normal for that patient. Sunset eyes, where you can see the pupils and the iris is down here and you can see white all above it. That's a late and bad sign of increase in cranial pressure, so we need to know that immediately. A fontanelle in a baby, if it's full, tense, pulsatile, you should be able to feel the crater where the fontanelle is, even if it's full. And if it's so tight that you can't feel that, then it could just be a real tense fontanelle, so that could be alarming as well. And then increased head circumference. These little babies should be having their head circs done daily as part of their assessment. And we also will be doing that because we're maybe the same person over and over. So it's a little bit more consistent than having multiple people, but it's still part of your assessment and we will be checking those as well. We do have a brain that's around that has our phone numbers on it. The main number on the brain is the top number, the 502-561-3123, because you may not know who you need. And that number will be attached to someone, whether it's a weekend, day shift, holiday, any time of day, someone will be attached to that number. It might be sent to their cell phone, it may be sent to their pager, but that's the best way to reach somebody if you don't know who to reach. Like the top two numbers, Julianne and mine, pagers don't even work. The others do carry their pagers, but it helps to not have to figure out which one you want. It could be that Peggy came by and said, call me when mom gets here, I'll come talk to him about the surgery. And if you want to page just her, that's fine. But I wouldn't continue to do that because it could be that she's in the OR and somebody else will answer that other number as well. So it's safest to do the main number, our hot potato number, if you're trying to reach us. And if you have any questions, since you're not here in person, write down your questions. And when I send out the email about who I need to see, the OR people or the PICU people about the drains, you can also you can email me back those questions, or when we get together, we can talk about those. I want to make sure you have all your questions answered. You can always email me. I'm joy.comingore, COMINGORE, .org, or at nortonhealthcare.org. So feel free to email me any questions that you have, but I will be trying to get in touch with you soon to get together in the PICU or in the OR to go over these. Thank you.